as well that day. I provided an alternative. One as an option, it quickly came into my mind, oh, we're thinking about Prozac. We could add Zyprexa on board because there's actually a combination pill of Prozac, Zyprexa. The brand name is Symbyax, and it's for bipolar. And I said, for our purposes, we can prescribe them separately and take them both for the same effect. And I asked her to let me know which one she would prefer. And she responded, I think I would like to do the Seroquel with the Valium taper.
Okay, so that suggested alternative actually was on at 12:37.
Correct.
And then at 1 o'clock, she elects that she'd like to do the Seroquel with the Valium and asks for you to call in the Valium and the Seroquel.
Yes.
Okay. So that's on December 7th, right?
Yes.
On December 8th, at 6:35 a.m., she sends you a message saying, did well last night, need Valium, feeling panicky, don't know if ready to taper as quickly as planned.
Yes.
Kind of paraphrasing, but.
Yeah, she exclaimed, I actually did really well last night with the Valium and Seroquel. I mostly slept from 9 to 5 with a few wake-ups, but was able to go back to sleep. She was concerned that she felt like she needed to take the Valium around 5 p.m. because she was feeling panicky. I feel really dependent on it. Can I taper any slower?
And what was your response to her request for a slower taper?
I said, I'm hesitant to taper any slower. Remember, Valium has a really long half-life, 100 hours, so you will have some on board in your system throughout the weekend.
And why were you hesitant to taper any slower?
I felt like she was anxious about being dependent on it, and so I was trying to facilitate the process of tapering her off, and I was clinically thinking we could cover her symptoms of anxiety as we titrated the Seroquel, because Seroquel actually has several clinical trials that show it has really good efficacy for anxiety.
And this conversation about the request to taper, that actually goes into December 9th of 2022, correct?
Yes.
And in her response to your indicating you were hesitant to taper, she indicates that she took the 5 milligrams of Valium and that she didn't have any left and that she was afraid that she was going to take Ativan.
Correct.
And had you recommended to take Ativan as an alternative or in lieu of Valium?
No.
Were there any more communications on that day, December 9th of 2022?
Yes.
What were they?
Later that afternoon, Lindsay and her husband called.
Okay. And so did you, fair to say they called the clinic, leave a message, and then you called them back?
Yes.
And when you called them back, what was the nature of that conversation? What did you guys talk about?
Her symptoms, we discussed that the plan was to taper the Valium over the weekend, but they both agreed that Lindsay's symptoms were too acute. She's sleeping better, but still waking up with panic symptoms and intrusive thoughts, feels numb, has thoughts of SI, but no plan and no intent. I encouraged her to engage with women and infants in Rhode Island to complete an intake for a partial hospitalization program. But she was able to contract for safety over the phone with her, with the 3 of us on the phone, that she didn't have a plan, no intent, that she would reach out if needed. I did agree to continue the Valium until our next appointment, which was scheduled for 12/13. I prescribed it as 5 milligrams, but I advised her she could take a half tablet twice a day, so 2.5 milligrams twice a day.
Walk me through that. She had She had indicated to you that she wanted to slow the taper.
Yes.
And then you said no, that wasn't a good idea.
Right.
And then on the 9th, they call you and say that she doesn't want to taper. She wants to stay where she is, right?
I think it was that same day. The messages were earlier in the day, and then later in the afternoon, around, it's noted at 16:10, so 4:10 p.m. that she and her husband then called, advocating to stay on.
And in advocating to stay on the Valium, that she reported she's still waking up with panic symptoms and having intrusive thoughts, feeling numb, right?
Yes.
So in addition to agreeing to continue the Valium, did you make a recommendation about the Seroquel?
Continue the titration.
So when you say titration, what does that mean?
So I had recommended 100 on day 1, 200 day 2, 300 day 3, 400 day 4. This is the manufacturer recommended titration schedule to treat manic symptoms. Because again, I had shared with her, I think this is a mixed manic, hypomanic state. So that's what I was targeting.
Okay, and so as far as Seroquel goes, there's some guidance you get about Seroquel that's put out by the FDA, right?
Correct.
And it talks about dosage and administration for every drug, essentially, right?
Yes.
And as far as Seroquel goes, there is different recommended dosages or ranges for different mental illnesses that you're treating.
Correct.
So in this instance where bipolar is in your differential diagnosis and you're recommending titrate up to 400, is that consistent with the thought that you believe she had bipolar diagnosis?
Right. So I was thinking it was a mixed manic state or possible hypomanic state. A mixed manic state is when patient has symptoms of mania, like poor sleep, no loss of energy, but they also can feel depressed, numb, suicidal. It's sort of like it's a mixed state. It's a mixture of symptoms. A mixed state presentation is clinically acute. It's unstable, so I really wanted to get the manic symptoms under control. I really wanted to get her to sleep.
And so going up slowly to 400 milligrams, what's the recommended dosage range for somebody with bipolar disorder of Seroquel?
For somebody, a manic presentation, you can titrate over days rather than weeks. You can actually go up to 800 milligrams.
And so even though you had previously indicated to them in your December 6th meeting that you were agreeable to discontinuing the Seroquel, based on our presentation in the days following, did you change your recommendation?
Correct.
And with the increased Seroquel that you had requested as of December 9th, she was reporting sleeping better, right?
Correct.
And that had been something that had been a recurring concern in your interactions with her, sleep?
Yes, my understanding was that she had been sleeping poorly since October.
And was there, when you say you were recommending partial hospitalization during that phone call, did you give a particular place in which you would recommend her to try to seek treatment?
Women and infants.
And that's in Rhode Island?
Rhode Island.
And are you familiar with whether they have particular perinatal or postpartum programs there?
They specialize.
After that call with the Clancys on December 9th, when was the next time you had contact with Lindsay?
December 9th was a Friday, so I believe it was Monday, December 12th.
Now, people are able to send my chart messages all hours of the day, every day of the week, right?
Correct.
But in this instance, you did not receive any messages over the weekend?
No.
So the next my chart exchange was actually on December 12th of 2022, correct?
Correct.
Now, on December 12th, do you recall who initiated the contact via my chart?
Lindsay?
And at 1:59 p.m., she sent a message to you saying, I've been noticing on my Apple Watch that my heart rate has been fluctuating more than usual. It has been going from 56 to 136 within a matter of minutes. I'm wondering if this is a side effect of the Seroquel and if there's anything I should do about it. Thanks, Lindsay. Do you remember getting that message?
I do.
And again, at that point, as of December 12th, you had recommended the titration plan going up to 400, right?
Yes.
So by that Monday, where should she have been if she was following your instructions?
400 milligrams.
And did she report to you whether she took 400 milligrams of Seroquel?
She reported she was taking 200 milligrams.
Did she say why?
No.
But your recommendation was that she should have been up to 400 at that point.
At that point, yes.
As far as the concerns about the fluctuating heart rate, were you able to address that with her in a response?
Yes. I explained that medications like Seroquel can cause something called orthostatic hypotension, which is basically when you get up from sitting or standing, your blood pressure doesn't compensate in time, so it goes low, and people can feel dizzy. I explained that the mechanism for that is alpha adrenergic blockade, so the alpha receptors that help us with like adrenaline. They're also part of the picture here with Seroquel. It's often accompanied by orthostatic tachycardia, meaning getting up from sitting to standing, your heart rate can fluctuate. I said both can be common in the first days of medication exposure or when the dose is being increased. It's generally benign, meaning non-harmful, and self-limiting, meaning it goes away on its own over time. I also advise it sometimes necessitates slowing a dose titration or dividing a dose into like 2 or 3 smaller doses.
Okay. And so with this response and trying to address these concerns, you're aware that she had spoken to the nurse that morning?
Correct.
And that she had expressed to the nurse a desire to get off the medications altogether?
Correct.
And what was your response to that?